I'm the director for the Child Injury Prevention and Injury Care HIT, which is called CIPIC. And what I thought I'd do is, we were asked to talk about what does the HIT actually do. So I thought I'd describe the challenges that we're trying to tackle and how we're trying to approach them. So we think we've got three main challenges. One of them is around prevention of injuries. The second is around care for children who are injured. And the third one is around rehabilitation of those children. So our first challenge is the preconception that injuries in children is an accidental thing, the children in the wrong place at the wrong time. They're not. Accidents don't happen by accident. There are highly predictable patterns and sets of circumstances that lead to child injury. So if we can spot those patterns and circumstances, it means we've got an opportunity to intervene. So there is something that we can do to stop these accidents from happening. This is a photograph I took on my way into work one morning. I don't know if any of you can see, but there's a zebra crossing just 20 yards up the road from this parent and child. The care challenge that we're trying to tackle is a key one for the acute trusts in the city, particularly now for University Hospitals Bristol, who are our sponsor organisation. In the Children's Hospital, the emergency department has huge volumes of children that present to them with relatively minor injuries, bangs to the head, ingestions, things like that. Most of these children don't have long-term problems or they're not challenging to treat, but the volume of those children coming into the system is quite demanding. And then at the other end of the spectrum, we've got a much smaller number of really very major trauma children who require long periods of hospital admission, multiple teams working on them, and very prolonged rehabilitation. And what we're not good at is then helping those children get back to their normal activities afterwards. So that's where it links to rehabilitation. We ran a workshop as part of our HIT with the rehabilitation therapists across the city. This was the mapping of their service in UHB for the rehabilitation therapists. There was a completely different map for MBT, there was a completely different map for the community therapists. None of the maps overlapped. Okay, so the situation, the system for delivering rehabilitation care to traumatised children in the city is highly complex and isn't at all joined up. And for something like rehabilitation, there's very little evidence base. So actually they don't know whether or not their service makes an impact. So there are our challenges. So our proposed solution was that we should try to join up these bits of the system. So what we thought of is we wanted to look at the whole care pathway for injury. So we wanted to prevent injuries where we possibly could. If we can't prevent the injury, we wanted to make sure that what happened out of hospital was as good as possible. So this is the first aid that parents give to children or schools give to children. This is what the paramedics do, the ambulance service. One of our partners is the ambulance service. If they then get into hospital, is the care that they get efficient and effective? Is it evidence-based? And what can we do to get them out of hospital in the most timely fashion so that we can get them back into their education and their usual activities as soon as possible? There's very little joining up at the moment between health, education and social care. So there's a big national drive for integrating health and social care, and we could certainly tackle it here on this subject here. If you have children with major head trauma, for example, getting them back to school is a real challenge. So who's involved? We decided to tackle our HIT through 4 clinical leads. So we're looking at 4 key areas, burns and scalds, head injuries, fractures and major trauma. And each of those topics has got a clinical lead. So if you like, they're my key people that I try to liaise with on a regular basis. But because they're all clinicians, they need help in those other bits of the system, like rehab, out-of-hospital care and prevention. So myself, Sam Matang from the ambulance service and Louise Lloyd from the rehabilitation teams are actually there to help support those clinicians in tackling the other bits of the system. And we try to have a cross-cutting theme where we're involving parents, children and young people. So that's, if you like, the core team, but actually who is involved has got much bigger. we've now got a sort of email group of about 50 names across a whole range of different disciplines, and this is great, but there's also a challenge of how do you actually make this HIT feel meaningful to such a diverse group of professionals and practitioners. So keeping them involved, I think, is going to be a challenge for us. So what does the HIT actually do? Well, what we aimed to do when we put in our application form was quite ambitious. We had to put in short, medium and long-term goals. And we were sort of looking ahead. Our long-term goals were sort of 10 years' time, and we were encouraged to be ambitious, and we've tried to be ambitious. We were actually designated 15 months ago, and the reality has been quite interesting, trying to sort of get the thing up and running over the last 15 months. So what we have achieved is we had a nice launch event in September of last year when we got those 50-odd people to come along and sign up and take part in presentations and workshops, which was very good. We've run 2 workshops for the rehabilitation therapists. We've developed and consulted on a PPI strategy, and some of the teams have had some grant successes, which is great. So I think we've sort of established a bit of a network. The challenge is, I think, has really been capacity of my clinical colleagues to contribute. So I don't know if you're aware, but there's been a major service redesign in Bristol where there's been centralisation of specialist paediatric services. So huge teams have moved from MBT into UHB in May. And for those 4 clinical topic theme leads, they have been completely preoccupied by actually making sure they've got enough beds, they've got enough staff, they've got a building, you know, completely practical stuff around caring for the children that they look after. So they haven't had capacity to buy into doing anything extra. So I'm kind of hoping that centralisation, now it's out the way, we've got some space to do some more creative work. Data sharing is a key challenge for us. All of those different organisations that are involved, they have different data sets on injured children. None of them share the same fields, none of them routinely share their data. Getting a picture of whether or not we're making a difference is going to be quite challenging unless we can get over data sharing issues. Putting our PPI strategy into place, so we've got the strategy, but actually implementing it and making it inform the work that the HIT does has been difficult for capacity issues because we had somebody helping us develop the strategy but not there to then implement it. And I think we will only have achieved a difference if we can actually look at integrating across that care pathway. I think it's fair to criticise ourselves for saying that at the moment we're still very siloed working. So the working that's going on in prevention is still in prevention. The clinical teams work within their clinical teams. The rehabilitation teams work amongst themselves. We're not doing projects that are tackling the interfaces between those areas, and I think that's what we really need to do. So if we want to make system change, that's what we've got to do. And I think there's huge potential for us to do more around education. Some interdisciplinary, interprofessional training needs are starting to emerge, and we haven't looked at how to tackle those yet. So the future, we've got our next public engagement event is going to be on the 4th of September. It's going to be down at the Watershed. And we've got, David's coming to open it, which is very nice. And we've got some speakers from UHB, our sponsor, which is great. So hopefully that'll motivate things again after centralisation. Marcus and I have developed a proposal for creating a lecturer's post here at UE, which will be funded partly, well, mostly through the public health training programme to work across the SHINE and CIPIC HITs. So this is looking about how we make children's environments healthy. It's work in progress, we haven't got sign-off yet. And we're very interested about those opportunities that are going to hopefully arise through the Clark and the AHSN. So our potential, we think, is we've got the potential to stop those injuries from happening if we get the prevention bit right. But if we can't prevent those injuries from happening, we want the best possible outcome for those children. And ideally, we could end up sort of setting a national standard for how we integrate injury care in Bristol.
Great, thanks. I just want to give you a flavour of the HIT called Shine, Supporting Healthy Inclusive Neighbourhood Environments, which is sort of quite a different HIT. I'm Marcus Grant. I'm an associate professor in the Faculty of Environment and Technology. I'm in the Department of Planning and Architecture. So our HIT brings in built environment professions in terms of town planners, town and country planners, urban designers, transport planners, architects, landscape architects into the sort of healthy city realm. So just give you a flavour of what we've been doing in our approach through sort of 5 ways that we're working. So one, we work through spatial planning. So I suppose when you talk about engaging with commissioners, our commissioners would be the people who are developing the city and spending millions of pounds, whether it's developers or sort of city urban planners, millions of pounds flowing into the city in the form of the city and the neighbourhoods all the time. And it's bending that funding so that we can create healthier places. So we work through spatial planning, through spatial planners. We use a wider determinants of health model, and we see our sphere of activity, arc of activity if you like, as the dark blue there, natural environment, built environment, controlling activities, living, playing, learning, working, shopping, moving, and the ability for people to do those in a healthy way or not be able to access a healthy lifestyle is partly determined, as evidence shows, through some of the spatial form, whether you have access to a local park, access to local shops, if there's something in the neighbourhood to walk to, traffic, air quality, etc. So we're looking at that side of healthy environments. We're working quite upstream in that we start with the physical aspects of neighbourhoods, and we're very much focused on the neighbourhood as the unit within the city, because then we get good traction with communities and working with communities. So neighbourhoods and places where communities in Bristol live, work, learn and play, helping create healthy places to grow up and grow old in, aligning city development with healthy lifestyles, well-being, inclusion, and the aspirations that Bristol has to be a green city, and that the mayoral aspirations, etc., and demonstrating, I suppose, through the policy environment that the green city is also must align with the healthy city, and these must be linked together. And also, of course, bringing through the academic side, the sort of sound science, but linking that with community voices, and we've been working specifically in 5 different communities in Bristol, and the practitioners, the built environment practitioners, to support Bristol as a healthy city and reduce health inequalities. And our sort of talisman, if you like, is that the places we create can determine our health. And it's not a physical determinism saying, you know, design like that and everyone's going to be healthy and happy, but it's part of the determinants of health, is the ability of the environment for people to access food, to live in a safe place, to have their kids grow up in an active way, etc. We're also working upstream in that we work through the whole life course, if you like. So you've got the healthy standard of living, of course, access to work, employment, huge determinants of health and the trajectory of health going forward in life, the burden, if you like, or the accumulation of positive and negative effects on health and well-being through the life course, but also the healthy neighbourhoods and environments. And just as a couple of examples of actions we've actually taken and successes at the sort of bottom end, if you like, kids being active and families being able to cycle. We've actually changed in the legislation in Bristol the number of cycle parking spaces, secure cycle parking spaces per household that developers are required to have. So this is a change in planning policy, and it was 1 space per dwelling. We've moved it up to 1 per bedroom. We said that was inadequate and hadn't moved for 20 years, totally out of step. I took that to a planning inquiry with an inspector. We put health evidence before them, and that's been taken. So that's at one end. At the other end, Susan Audrey, we've, through, again, putting health evidence in, we've reversed the closure of public toilets. So if you like, at the other end, I'm talking about older people, I'm talking about the environment there that's, you know, some people can mean that they can't get out into the environment. We've actually changed that, and the Mayor has changed his closure programme. So we're working very much in a policy environment that feed in good health evidence in, so it's evidence-based policy in that environment. Working with new opportunities, long-term effectiveness of Shine involves 3 approaches. One is supporting communities and public health professionals in neighbourhoods as they play a greater role in local planning. So there's a big opportunity now with the Localism Act, and there's been different neighbourhood planning acts that communities actually get a say now, or much bigger say, in their neighbourhood investments and neighbourhood development. And we've been working with 5 pioneer communities who are putting together neighbourhood plans, and we're feeding in that sort of health lens for them, health impact assessment. You know, are you creating the place here to grow up and grow old in? Are you creating the place that you want to bring your families up? What is stopping you in the physical environment having those healthy lifestyles? At least asking those questions and getting them to demand better of local neighbourhoods. If we promote physical change, that itself puts long-term effectiveness in, because the physical environment, you know, is there for 80, 150 years. If we can make physical changes, this embeds that healthy environments in Bristol. And we also are starting to influence the planners in Bristol City Council, so they're doing our work. So before we were doing health impact assessment and feeding them the results. Now we're training them up so they get to say, oh, that wouldn't be very good, you know, putting the food shop there and the old people saying that they can't get to there, et cetera, et cetera. So we're actually training them up to do the work, so leaving the capacity. So it becomes a norm that planners, and they should be looking at population health, of course, so putting that back on their agendas. So we're starting to make that the norm, that when you're looking at a planning application, you're looking at, does it support a healthier population? Working with a wider health force model. This was the organogram that you're demanded to put in, not such one, but you're not demanded, or you used to be, in the HIT application. And you can see there's we proposed to have 4 directors. One was the Director of Public Health at the time, Hugh Annett, who asked us to set up this HIT because it sort of builds on some work that Bristol was doing anyway. And it sort of built it out. What the HIT did, it built it out because we didn't have a relationship at that time to University of Bristol or to the other acute trusts. So we've got Adrian Davis, Hugh Annett as was, but that's a vacant space for the DPH, Susan Audrey and me as directors, and then this sort of leadership team, and you'll see some of the other names in the room, Selina Gray, particularly Stephen Hewitt, who's the Healthy Urban Planner that had been seconded into the planning department with NHS money. So there's a sort of team there, and linking through from Susan Audrey into Ashley Cooper and his team, and also Angie Page and all the amazing work they're doing on walking and activity in the built environment. So sort of linking through into both University of Bristol and UWE, which has other work going on, particularly in the Transport and Society Research Group. Work with known expertise, bringing in this built environment skills, which is sort of quite unusual often within this sort of health framing, but I think very necessary. Approaches across the team, we've got mixed method approaches, quite a lot of experience in participatory approaches and involving, as I say, communities in health impact assessment, etc., translational research, spatial analysis, policy appraisal and development, and also starting to build out an offer to the other HITs, in that with this sort of wealth of built environment and spatial analysis, GIS analysis of urban form, there might be something we're offering the other HITs where they're looking at public realm, etc., and hence the tie-up with Julie and some conversations with Selina. You know, there's bits where they could welcome those skills. Selected activities to date, I've talked about a couple. We're doing quite a lot of evidence translation, and particularly translating evidence so that practitioners, and here I'm meaning built environment professionals, can really understand it. So they're not reading referee journal articles. They don't understand what systematic reviews are. They need quite digested information that they can just put into a policy paper or council briefing paper. Suzanne Audrey is doing a lot of work on NHR study, on healthier by design, and as I say, bringing in work of Ashley Cooper, and we're actively working with the Architecture Centre in also the sort of dissemination of that work through exhibitions there. We've been working a lot with Bristol City Council Planning and Transport Policy. We've actually put in a protocol where they do a health impact assessment now for certain planning applications, that we triage certain planning applications, go and we do a desktop health impact assessment and feed that back into planners, for instance, but a lot of other policy changes. City food systems, we've got Public Health England money, actually Public Health England money also for the evidence translation. Recently 2 grants from Public Health England to look at work there, and we've done a developmental review looking at the whole city region food system for Bristol and how they can support access to healthier food. And finally, we're proposing a big conference linking this green agenda and healthy cities agenda for 2015, for the autumn 2015 part of the Green Capital. So just to recap, so we're aiming to strengthen population health evidence base and research capacity, developing and evaluating interventions with a focus on healthy neighbourhoods and translating findings for implementation in Bristol and beyond. And I think that's just the little flyer there for the big conference, Cities of Health conference, next October. And again, that talisman, the places that we create can determine our health.